My name is Lisa Hirschhorn. I am a member of the Robert J. Havey Institute for Global Health. So that's a pitch for all of you to join who are not already members, and also the director of the Ryan Family Center for Global Primary Healthcare. And I'm absolutely delighted for our first Friday to introduce Dr. Jean Kwan, who will be talking today on access to heart failure care in rural low-income countries, the challenges and opportunities. I'm absolutely thrilled to have Jean join us, and also again, just welcome you to become an Institute member to receive access to resources and services, to support research infrastructure, and learn about some of our fantastic education and training opportunities. And somebody will put into the chat the link to globalhealth.northwestern.edu/members. I've actually had the absolute honor and pleasure of knowing Jean for many years. We worked together in Rwanda and have really followed and learned a tremendous amount from him about thinking about cardiology in areas where, when he first started, a lot of people were ignoring that as a problem. So Dr. Kwan is a cardiologist and global health researcher committed to improving healthcare access for the poor. For over a decade, in partnership with local organizations, he's led the development, implementation, evaluation, improvement, and dissemination of integrated chronic care programs in rural, low, and middle-income countries. Really tackling the challenges of improving access to point-of-care diagnostic tests and care management through task shifting, with experiences in rural Rwanda, Haiti, Malawi, and Liberia. There will be time for questions following the presentation, in which we welcome you to submit questions during the talk to the Q&A function at the bottom right corner, and throughout the presentation and at the end. And now, Dr. Kwan, over to you.
Great, thanks so much, Lisa. Thrilled to be here with the Institute for Global Health. I've heard a lot about it, talking with Lisa, particularly over the last, I don't know how many years you've been there, 6, I'm guessing. Lisa's been a tremendous mentor of mine, and I'm very, very thankful for her mentorship and her help, and glad to be here. Lisa, I first met in 2008 in Rwanda. I remember on that trip in particular, a couple of memorable things. One is I heard the term M&E for the first time. I didn't know what that was. I was a complete newbie to global health. Little did I know it's going to become the backbone of what I'm doing. And then the second is Lisa actually helped me design my very first access database to do chart extractions for our heart failure patients in Rwanda. That was my first introduction to using Access as a data collection tool, and it was my last time I've used Access as a data collection tool. So as Lisa mentioned, I'm a cardiologist at Boston Medical Center, and been doing global health work together with an NGO, Partners in Health, for 14 years or so. And I'm going to be talking today about access to heart failure care in rural, low-income countries. What have been some of the challenges that we've experienced with helping to improve access, and what are some of the opportunities for growth? First, I'm going to take you to one of the countries I've worked in, which is rural Haiti. Let's see. Rural Haiti. This is a patient, his name is Valder. He lives in rural Haiti in the Central Plateau, which is a very mountainous region. He came to us many years ago because he was having difficulty breathing, and having difficult breathing or shortness of breath is there are a lot of things that can cause that particular condition or that particular symptom. At the time when we met him, he was 16 years old, weighed 71 pounds or 32 kilograms. He reported having shortness of breath with walking around his house. And as many of you work in low-income country settings, one's home is usually relatively small. So even just going from room to room was a challenge for Valder. This is Valder standing next to his father. And you can see even at age 16, for the most part, a lot of 16-year-old boys, young men will be pretty much near what their full adult height would be. You can see compared to his father, his projected height would probably be about a foot and a half taller than he is now. But for some reason, his growth has been stunted. This is him in front of his house, and he, by chance, happened to be born in Haiti, which is one of the poorest countries in the world, poorest countries in Americas, where 78% of people live on less than $2 a day. If you've been following the news, there have been a lot of chronic on chronic tragedies within Haiti that are deeply affecting the people and making it very challenging for the country to escape some of these poverty traps that they're in. Valder presented to a rural referral hospital at which I was working at the time in Mirabelais, which is right in the Central Plateau. Before I get to that, the Haiti itself has a population of 10 million people. And like a lot of the places where we work, there are very few doctors. There are only 2.5 doctors for every 10,000 people. There are 16 cardiologist specialists, all working in the capital city. There's a very common phenomenon in other low-income countries where the subspecialists, the ones that can really deliver that expert care, oftentimes live in the cities and are very distant from where patients are in the rural areas. This is a picture of outside of Valder's home, and you can see how hilly and mountainous central Haiti is. And even if one's having shortness of breath just walking room to room, one can imagine that doing other activities of daily living, even going to fetch water at a pump, could be very limiting for Valder. So we met him in rural Mirabelais, and with his constellation of symptoms, his shortness of breath, we did an echocardiogram for him, and you should see a video playing just to orient everybody. This is an echocardiogram taken from the front of the chest. The structures here represent the different chambers of the heart. The most superficial structure is the right ventricle. This is the septum that separates the right from left ventricles. And this is his left atrium. There are valves that separate the different chambers that regulate one-way flow within the heart. This valve here is the mitral valve. Let's see. Yeah, that valve there is the mitral valve. Over here, this is the aortic valve, and this is his aorta. One of the main findings we have of Valder is that his mitral valve is much thicker than it should be. It appears much more white on ultrasound, which means that his valve structure reflects a lot more ultrasound waves than would be normal, and that's because of deposits of calcium from long-term inflammation. This is a very characteristic sign of rheumatic heart disease, specifically causing restriction of the opening of this mitral valve, which is called mitral stenosis, one of the major manifestations of rheumatic heart disease. So Valder has rheumatic heart disease. He's had it probably for many years, and just as his mitral valves become worse and worse, narrower and narrower, his symptoms are becoming worse and worse as well. So this is just one type of cause of heart disease and heart failure. And for those of you who are not clinicians, just understanding what is heart failure. This slide we actually took from a community health worker-led education intervention that we're delivering in Haiti directly to patients. This is in English instead of in Haitian Creole. But what the heart does is that it pumps blood to the rest of the body. If you're an infectious disease doctor, its job is to pump around the antibiotics to help treat the infections. But for the rest of the time, it's really pumping around oxygen, so distal tissues and muscles can use that, and retrieving carbon dioxide from those tissues. Heart failure is a chronic condition. It doesn't necessarily have a cure, but it can definitely be controlled and managed, similar to a lot of other chronic conditions, HIV being one example of a chronic condition. And heart failure tends to happen when the heart is weak and it cannot pump enough blood for the body's needs. And the way that manifests is that there are a lot of different causes for heart failure. So there's a final common syndrome for heart failure symptoms, those being shortness of breath, for example, but there are a lot of other specific causes. Very common causes that we'll see in low-income country settings are, one is cardiomyopathy, which translates as heart muscle disease, or it's something wrong with the muscle itself, the muscle cells. Rheumatic heart disease causes faulty heart valves. There are other acquired heart valve diseases as well. Congenital heart anomalies, which are abnormalities at birth, abnormal connections between different parts of the heart chambers, valves that don't form properly, that can all lead to inefficient heart pumping. Having high blood pressure, whether it's systemic or in the pulmonary circulation, can cause problems, either leading to heart failure or problems of the right side of the heart. And a major cause that we actually see more in high-income countries is ischemic heart disease or coronary artery disease, where cholesterol buildup and plaque builds up within the heart arteries, causes not enough blood supply to the muscle of the heart, and part of the heart muscle dies because of not having enough blood flow. So there are many different causes of heart failure, but they all lead to the same syndrome, and the same syndromes are the symptoms of having shortness of breath, particularly when trying to exert oneself, walking on flat ground or even uphill or stairs, getting extra fluid, particularly swelling in the legs. Some of that extra fluid can go into the lungs, making it difficult to sleep when laying flat, having a lot of coughing when laying flat, feeling fatigued and not being able to do one's normal activities. For children, not being able to keep up with, playing soccer with one's classmates, having a persistent cough that just won't go away, sometimes having chest discomfort and even feeling rapid or strong heartbeats. So all of these symptoms together represent the syndrome that is heart failure. And heart failure is defined as a combination of symptoms, some physical exam signs, and usually some other diagnostic tests, whether it's laboratory tests or imaging tests. And one reason why it's been challenging to study heart failure is because there are so many different causes of heart failure. And in a lot of epidemiologic studies, epidemiologists really want to understand what is the underlying cause, what is causing the morbidity that we're seeing. So in most epidemiology studies, all of these different causes are broken up into their own components. What proportion of heart disease is caused by coronary disease? What proportion by cardiomyopathy? What proportion by rheumatic heart disease? But if you're a clinician working in rural Haiti or rural Rwanda, for the most part, when you're seeing the patient for the first time, you don't really care what the underlying cause is. You just know that they have the syndrome of shortness of breath, volume overload, and you want to figure out how to treat them as best as you can. Of the type of causes that we're seeing in our countries where we work, these are 3 bar charts, one for Haiti, amongst the older population, one in Rwanda that included children and adults, and one in rural India as well. We see a lot of commonalities. One is that in the orange, cardiomyopathy makes a very large component of the heart failure burden. The next larger components are things like rheumatic heart disease, seen in the yellow, right heart failure, which is caused by pulmonary hypertension or increased pressure within the lungs, hypertensive heart disease, which is having prolonged exposure to high blood pressure, and then congenital heart disease. One cause that's particularly absent from a lot of these hospital-based registries is ischemic heart disease. In the United States, one of the #1 causes of heart failure is ischemic heart disease, and that's true in the high-income country settings. But if you go to rural low-income country settings, it's virtually non-existent. I think within Haiti, to give you a sense, within a given year, we'll probably see 1 or 2 patients that is having a heart attack or myocardial infarction. We'll compare that to the number of heart failure, and we see about 4 or 5 every day with heart failure from different causes. So the heart failure burden, at least in rural low-income countries, is much, much higher than ischemic heart disease. And these cardiovascular diseases that affect the poor, we feel are all related to poverty. It's just a manifestation of the poverty in which they're living. Common causes of cardiomyopathies tend to be things like viruses. HIV can cause heart muscle dysfunction. Other viruses, such as coronaviruses and enteroviruses, we've heard a lot of COVID-19 causing myocarditis in severe manifestations. Chagas disease, which is a parasite-borne disease, parasite-mediated disease that affects the heart muscle. Even having micronutrient deficiencies, such as thiamine and selenium, can lead to cardiomyopathies. So having poor nutrition can lead to having heart disease. Peripartum cardiomyopathy is a unique type of cardiomyopathy that affects women toward the tail end of pregnancy or the first few months of pregnancies. We know that patients who have had multiple pregnancies combined with malnutrition are more at risk for having peripartum cardiomyopathy. There's a genetic predisposition as well, and there are particular areas that are enriched in the underlying genetic risk, those risk alleles, and those are particularly in Haiti, Nigeria as well. Get a lot of patients with peripartum cardiomyopathy. Rheumatic heart disease is actually an infectious disease caused by recurrent group A streptococcal pharyngitis. Patients get recurrent pharyngitis, particularly when they live in crowded living conditions, lack of access to very simple medications that can treat the pharyngitis, which is penicillin. And over time, there's an immune response to the pharyngitis that has an autoimmune effect, or actually attacks one's own heart valve tissue. So as the body is trying to fight off the streptococcal bacteria, the antibodies that are generated actually attack the heart valves themselves. So getting early access to penicillin, access to primary care can actually alleviate a lot of the rheumatic heart disease, which is why we rarely see rheumatic heart disease in high-income country settings anymore. Congenital heart diseases are made more prevalent by some other infections, such as maternal rubella and other micronutrient deficiencies like folate. Right heart failure can happen when there's pulmonary hypertension, things like air pollution, whether that's ambient air pollution from dust, microscopic dust, or other indoor air pollution from cooking stoves and smoke. Tuberculosis can attack the lungs. Schistosomiasis can also lead to pulmonary hypertension, right heart failure. And pericardial disease, so having fluid around the heart, can be caused by things like tuberculosis, having advanced malignancies. Breast cancer is a very common reason to have pericardial effusions. There are a lot of kind of late diagnosis of breast cancer that manifest as pericardial effusions and heart disease. So all of these conditions arguably are related to poverty, whether it's exposure to infections, lack of access to primary healthcare and access to things like penicillin, living in crowded conditions, having food insecurity. A lot of these are related to poverty. And so thinking about this, it's no wonder why we're actually seeing these conditions in rural settings in low-income countries. In Rwanda, this is a family of one of our heart patients in Rwanda. In rural Rwanda, pretty much a vast majority of the patients are farmers, having things like dirt floor housing. Of our heart failure patients, more than half say that they're too sick to work. About half of patients have to borrow money or sell belongings to pay for healthcare, or have other manifestations of hardship financing to pay for their healthcare. And so it's in these settings that we're seeing patients and treating them with their heart failure. One way to do that, because we have very few cardiologists, here's a rundown of, in Rwanda, we have about 6 cardiologists for 12 million people. Actually, Rwanda just finally opened up their first cardiologist training fellowship, which is really exciting. Haiti has about 16 cardiologists for 11 million people. Liberia has 0. We're actually helping to train the first 2 Liberian cardiologists in the country. In Malawi, there's 1. But to compare, Boston Medical Center, we have 25. Northwestern actually has more. And in Boston, the whole Boston area, there's about 300 cardiologists, probably for about 5 million people in the greater Boston area. So you can see there's a very, very a gross need for cardiologist experts. But in the absence of being able to train experts, we've been working over the last 3 years, and it took us 3 years to get 2 Liberian a pediatrician and an internist to go for cardiology fellowship training in Uganda. We've been working for 3 years to get at least a second Malawi cardiologist trained. So training experts takes a long time. Yet these patients are here now living with these conditions. So thinking of ways to actually help those patients led us in Rwanda to think about using task shifting. And task shifting isn't anything new. We've been doing it for a long time, particularly with the growth of HIV care programs, particularly in the 90s. But we've been doing task shifting for using simplified focused cardiac ultrasound, where we have taken echocardiography, as complicated as it is, and really simplified it to components, parts, and treated heart failure as a syndrome, combining it with diagnostic categories that each have their own treatment. So using a simplified echocardiography algorithm and protocol, we're able to help frontline providers actually help categorize heart failure. They're not arriving at the final diagnosis or the underlying cause, but they're putting it into disease treatment categories. And then our nurses and clinical officers can initiate treatment and figure out which patients need to see the few cardiologists in the country and which ones do not. So I'm going to help all of you turn into echocardiographers. I was reading echocardiograms earlier today, and I'll admit, as someone who does this for a living, about 90% of what we do and 90% of the information that ends up in report probably has very little value. This is someone that does this job every day. But there are various findings that are incredibly high value, and that's where we focus this particular simplified protocol. In the upper left corner, the left ventricle here, it should be compressing in by about 50%. These walls should be coming around in by about 50%. You can see that these walls barely move at all. This is a problem of the heart muscle. The heart muscle is sick. This is cardiomyopathy. The the feature that we look at is called the ejection fraction, or the fraction of blood that's actually ejected. This is very low. This is very easy to identify for some of our trainees. In the right side, this is another example of rheumatic heart disease where the mitral valve is very thickened and calcified, has very restricted motion that has been attacked with inflammation over many years. This is a hallmark of rheumatic heart disease. In the bottom left, this structure that's toward the top of the screen is very, very large compared to what we're seeing in other patients. This is a patient that has dilated right ventricle because of right ventricular failure. And on the bottom right, this is a patient that has hypertensive heart disease. Their systolic or ejection fraction is very normal, but their blood pressure is very, very high because their heart has been pumping against very high blood pressure for a long time. So with simplifying echocardiography down to really 4 or 5 different findings, combine that with a little bit of physical exam, we're able to help train clinical officers and nurses and frontline clinicians to function as cardiologists in places where they don't have enough cardiologists. And so we've tried to really decentralize heart failure care outside of the capital. So in Rwanda and in Haiti, all the cardiologists live in the capital city, but that doesn't help the patient that lives 3 hours or 4 hours away on a bumpy dirt road. So the trainees that we have are able to identify patients with heart failure symptoms, be able to have echo images that are required using point of care ultrasound devices. Those images are then interpreted by the providers themselves, and they can make a treatment decision all without external experts giving input. And the way we've done it for a long time has been through hands-on teaching. This is the way it's done in high-income countries as well. You have a novice trainee together with an expert trainee side by side for doing a lot of different scans, seeing a lot of patients until that novice becomes proficient. It's the same way clinical training has been done for a long time as well. And we're trying to impart the skills of how to, for image acquisition, so how to take the pictures, then image interpretation, how to interpret those pictures, and then how to integrate that into clinical management. So literally 3 different distinct skills. In high-income countries, you have an echo technician or sonographer that does the image acquisition, and then their job is done. And then you have an echocardiographer, a cardiologist, interpret the images, generate a report, and then their job is done. And then you have the treating cardiologist or the treating clinician that then does the integration into the clinical management. So in high-income countries, this is divided amongst 3 different people. But what we've done is really incorporate it all within the same person. And there is Dr. Emmanuel Rusingizi, one of the few cardiologists in Rwanda, has been working with our team for over a decade. And here he is training 1, 2, 3 nurses who are nurses that have 2 years of post-undergraduate training. This particular case, we have a community health worker who's working there as well. So Dr. Emmanuel has trained a lot of our nurses over the years, and they're able to do that really well. The training, this side-by-side training, has been very labor and time intensive, where it's taken about 2 months total for training. We actually integrate heart failure care within other non-communicable diseases, including diabetes, hypertension, respiratory disease, more recently sickle cell disease. Over a given week, there's usually 1 or 2 days that was reserved for heart failure patient care training in echocardiography. So that equaled about 8 to 16 sessions with an expert, full day sessions. And so it's very resource intensive, but it works. We've shown that our nurse-driven echocardiography program has been able to have really high sensitivity and specificity for nurses performing echoes for each of these different disease conditions. Sensitivity and specificity are up in the 90% range for a lot of the different conditions. And there's a very high agreement between our nurse trainees and cardiologists. So with a lot of hands-on time, a lot of one-on-one time, there's ability to train nurses to be able to deliver, to be able to acquire the images, at least. But as we've tried to disseminate further within Rwanda and other countries, we've realized that we just don't have enough cardiologists to do this training. So we've tried to develop capacity building through developing master trainers, which is a very typical train-the-trainer model. So what we focused on is taking our novice, having a cardiologist involved to train them in basic focused cardiac ultrasound. Those trainees then develop clinical experience, and then we give them training of trainers, how they can become trainers. So that's the second point, that the cardiologist is involved to develop them into master trainers. And those master trainers that now have a lot of experience then train new novices who can then become basic focused cardiac ultrasound trained and then start delivering clinical care. So just before the COVID pandemic is when we trained our first batch of master trainers in Rwanda. And it came as a good time because then with COVID, with a lot of the travel restrictions to our master trainers, we're actually able to carry on training of new trainees in Rwanda over the last several years. More recently, though, we've found that even this is still resource intensive. And so we've developed some new training structures, including thinking about a flipped classroom that really has pre-work that's based on e-learning modules. Here are some screenshots of our e-learning modules. This one on the top has examples of heart schematics with congenital heart disease and other types of heart diseases. These are very interactive. They have videos or spoken audio, so trainees don't have to have the burden of reading. There's a lot of interactive. This is a matching game that the trainees have to incorporate and do along the way. So instead of it just being didactics, there's interactive features that promote engagement by the trainees. In addition to that, we've incorporated group work where the trainees teach their colleagues about their cases. Here's one of our training sessions where Sheila Clausen, who's a cardiologist that works with us, who's based in Canada, is training our team of Rwandan trainees, first giving group didactics and then doing bedside ultrasound training. And then we ask our trainees to perform 25 echocardiograms, some of them precepted by an expert, with an expert side by side, some of them with independent practice. And after they pass some proficiency tests, and we're considering them to have proficiency in the skill to perform it independently. At the end of training, particularly in Rwanda, it's very formal where everyone needs a certificate. But from there, a lot of these trainees in one of our first batch became like Nasan here, who's a nurse based in the western part of Rwanda, is now training other novice trainees here. So he's developed enough skills that he now is able to become a trainer. So we've had some success doing this training the trainer model. We are now doing this in Malawi as well, where we have expert clinical officers that are then able to train the next group of clinical officers at new hospital sites and new clinical sites. Something that we're newly exploring is how to incorporate other technologies actually into training this diagnostic skill. There are simulators to use simulation for echocardiography training. This picture on the left, you see there's a simulator with a black neoprene wetsuit on. This is the simulator itself. It's a torso that's a mannequin where a mock transducer is held by a novice trainee. And as they move this transducer along this torso of this mannequin, it changes the representation of the image on the computer screen. So in the absence of an expert cardiologist, in the absence of a patient even, you can help a trainee develop the psychomotor skill of image acquisition. And what we're testing now is actually whether these simulators can recreate the experience of image acquisition, and can this facilitate initial training for the assessment of competency. The particular simulator that we're working with has some other features. One is that it can show side-by-side images. On the left panel is what an expert image would be like. This is an image that's the appropriate image, where you can see all the structures really well. And on the right side, it shows the trainee image. So as a trainee, one can see how different their image is from what an expert image would be, and then can adjust their hand motions to try to approximate the expert image. The other is that on a 3D heart model within the torso, it can show the imaging plane. The optimal imaging plane is shown in green, going here from the upper left to the bottom right. And it can show that compared with the the actual imaging plane by the trainee, which is this one in blue. And as a trainee, you can see how off you are regarding the position of the probe and the rotation of it. So there are a couple of built-in features to help trainees actually do self-assessment to help them improve themselves and become self-efficacious with this training model. So we are soon going to be starting to incorporate simulation into our training in Rwanda and Haiti specifically. But it's one thing to be able to train nurses to be able to perform, acquire the images and to interpret the images. But the next is, what do they do with that data? Can they actually execute on that and treat patients the way that they need to be? As I showed before in our treatment protocols, each diagnostic category has its own treatment that's treatment based on the diagnostic category. So patients with cardiomyopathy should be placed on these three medicine categories: beta blockers, ACE inhibitors, and a loop diuretic. These are all evidence-based medicines. We know they have mortality reduction in large clinical trials, and they also help improve symptoms. And these are all very similar to guidelines that are developed in United States and Europe and high-income countries that we've adapted for our low-income country settings as well. And so our trainees are able to initiate appropriate medications, 70 to 80% of the time. In patients with mitral stenosis, we want them to be on a beta blocker. We want the heart rate to be low. The beta blocker will lower the heart rate and lessen the symptoms of mitral stenosis. They should also be on penicillin, which helps prevent recurrent episodes of strep pharyngitis and recurrent episodes of rheumatic heart disease. And some patients should be referred to surgery. Patients with mitral stenosis should be referred to surgery for evaluation in Rwanda specifically, in places with surgical capacity. And so our nurses are able to not only acquire the images, interpret themselves, but then use that information to help improve symptoms and improve care. And quality of care is pretty good in Rwanda, where we've had a program going on for 10 years. So for medications for cardiomyopathy, these are all the evidence-based medicines. Diuretic, ACE inhibitors, beta blockers have a very high adoption by our trainees. Spironolactone, which also has mortality benefit in cardiomyopathy, we've introduced recently. It only got on the essential medicines list from the WHO about 3 or 4 years ago. And we compare that to the very early stages of a new academic hospital in Haiti, where there was a lot less use of diuretics, ACE inhibitors, and beta blockers at that time. So we show what the potential is for improvement in terms of clinical management for these particular patients. And with using the appropriate medicines, symptom relief comes with that as well. But it's not, doing the diagnosis, getting patients on medication isn't enough by itself. As I mentioned in the beginning, heart failure is a chronic condition, just like HIV, tuberculosis, or chronic infectious conditions. And we know that getting patients into long-term care is really important. But in Haiti, we know that we have actually really low linkage to care among our heart failure patients. Of those hospitalized, about 11% die in the hospital, and they're there for about 10 days getting treatment in the hospital. But of those, and routinely when patients are discharged from the hospital, they're given 30 days of medicines and asked to come back to a clinic appointment that they have scheduled. But those that are linked to clinic within 30 days are only about a third of patients. So from discharge to linkage, this cascade is pretty steep. And from there, patients who are retained in care 60 to 90 days later is even lower. And we know that those patients who are not linked to care or not retained in care are not coming to the pharmacies to get their medicines, so they're just going without their medicines. And with those patients, what happens is that their symptoms come back. Their fluid comes back, their hemodynamics change, and then they oftentimes either end up in the hospital, end up suffering at home, or end up dead. And so it's one thing to be able to work on the provider end to help providers improve the quality of care that they're given by being able to help diagnose and initiate the proper medications. But without having chronic longitudinal systems to make sure that these patients stay engaged in care, stay on top of their medications, we know that these patients are just going to continue to suffer and continue to be in the hospital. So more recently, we've also focused not only on the provider end, but also on the patient end by trying to understand what are the facilitators and barriers of heart failure care. This is a qualitative study that we've done. A lot of very interesting findings. A few that I really want to point out of the specific barriers that we think are very actionable, that there were misconceptions by patients. These are patients that were treated for this condition. They were in the hospital for a week and a half. They had a lot of opportunities to get education by providers, and they did get education by providers, but they still had misconceptions. One was that medications could not be taken without food. Specifically for heart disease medicines, they don't need to be co-administered with food to help absorption. They're pretty well tolerated. They don't really cause that much nausea or stomach upset if they're taken on an empty stomach. But what we found talking with patients and even talking with providers is that a lot of patients are even told that they should always take their medicines with food. And it seems like this is really a residual from the way that antiretroviral agents were, education was given about how to take antiretroviral agents. Because earlier, a lot of the ARVs for HIV really caused a lot of GI upset, had to be taken with food, otherwise they caused a lot of side effects. I think that has really persisted within the providers. Providers are still giving this education. Patients have internalized it and understood it from a lot of different angles. So there's this persistent misconception among patients. Particularly in Haiti, it's challenging because there's a lot of food insecurity. So there are many patients that don't necessarily have food in the morning or have food to take for breakfast. And so if they don't have food because they're food insecure and they think they need to take their medicines with their food, turns out that they just don't take their medicines for that day. Another misconception that has to do with the difference between acute and chronic conditions are that patients oftentimes stop their medicines when they feel improved, when they feel better. Heart failure is a condition when one is filled with fluid, it really causes a lot of the symptoms. After being treated, particularly in the hospital, a lot of the fluid is eliminated from the body and patients feel much better. So they have symptom improvement, able to do some of the activities that they were not able to before. And in thinking that this is an acute illness, a lot of patients then stop their medicines thinking that they're better and they're cured of this chronic condition. But over the next couple of weeks, their fluid comes back and they're left feeling the same way that they were before. Another actionable item, a barrier where that many patients would forget their visits and appointments. They're very busy. They have a lot of other things, a lot of other priorities in life, particularly when you're living in a setting of poverty, trying to work as a farmer, trying to figure out where your next meal is coming from, trying to get money to pay for your child's school fees. That is all very burdensome, and oftentimes one's paying attention to one's health, particularly for adults, ends up being very secondary to some of these very primary and essential needs. Another major barrier we notice is that there's a lot of complexity with the way that the Haitian health system is organized and the way the hospital is organized, and that patients will come to the clinic, couldn't figure out where they had to go, just get lost in the chaos, and then not be able to see a provider for that day, and then go without their medications. So doing these qualitative studies actually led us to figure out some of these specific barriers and have led us to then develop interventions to try to address them. We also know that the patients who are the most well off are the ones who are more engaged in care. This makes sense because the patients who have the means to take a day off of work, take a day off from their busy lives to be able to come to clinic are the ones that are able to access the clinic. We did a study amongst chronic disease patients and assessed of those in different wealth quintiles compared to the general population, which of our patients who are engaged in clinic, which wealth quintile they came from. And a majority of the patients who are engaged in our clinic continuously were patients who are in the least poor quintile, or the wealthiest quintile. And this is despite having our hospital in the middle of rural Haiti, close to where a lot of the poverty is. And we see that a lot of the patients who are in the poorest conditions are the ones, fewer of those in the poorest categories are the ones who are less engaged in care. And so we then have to figure out, how do we engage these people who are the poorest of the poor how do we help them to promote more equitable care and keep them engaged so that they don't have decompensations from their chronic disease and their heart failure? One is by first trying to understand where the patients come from. This is a map of Haiti. Here is where the capital Port-au-Prince is. The hospital where we work is here in Mirabelais, which is in the Central Plateau. The catchment area for this hospital tends to be in this area here. There's a road that runs roughly east-west here along a river, where a lot of the patients will come from into this particular hospital. The shades, the darker shades show where patients are the poorest. The lighter shades show where patients are the most well off, have the least deprivation. We see that the patients who are in the rural regions tend to be the less poor compared to those that may come from an urban setting over here or a larger town over this way. And so understanding where our patients are coming from, where the patients are having the most amount of poverty can allow us to target some of our community-based interventions directly to the communities where those patients live. Let's see, I'm just seeing in the chat. I know I'm supposed to. Any idea where, this is a question from Alex, an ID fellow. Any idea where the wealth Q3 is least engaged? Why the Q3, why those that are in the median are less engaged? Let's go back to that. Yeah, it's a good question, right? It's not a linear distribution going from low to high. I think some of this may end up being because of the way that we actually categorize wealth in this particular study. We use a multidimensional approach to categorizing poverty in this particular setting. But I think if I remember, a lot of patients that ended up in the middle quintile were either bumped up either to less poor or to more poor categories. But that's a good question, because whatever community-based intervention will probably help the people in the poorest quintiles, but also those towards the median as well. Great, thank you, Alex, for your question. One way that we've tried to address some of these barriers, particularly in Rwanda, with a lot of success, actually has been with patient education. This is Francis, one of our nurses. He's been with us 15 years or so. He actually worked in the hospital before Partners in Health worked there, and he remembered when it was overrun by livestock, actually. But this is in the morning before a particular clinic where patients in Rwanda, the chronic disease clinic is organized in disease-specific days. So all these patients on this particular day have the same condition. And Francis got tired of actually trying to teach, not tired, felt that it was burdensome to teach each individual patient whenever they were coming into the clinic room, the consultation room itself. So he, on his own, actually started doing group education sessions before the clinic started, where his goal was to try to empower patients with knowledge, try to improve medication adherence for patients that have some type of tool that they need to use, whether it's a meter dose inhaler or self-injecting with insulin, try to teach them those techniques. And he felt that this was very much a reason why patient retention increased, particularly in Rwanda. And what he told me is that it's the main reason our patients keep coming back. They say, you would pay attention to us. And really having that relationship with patients and providers, even in the midst of an incredibly busy clinic, where provider is seeing 50 to 60 patients in a day, can really go a long way to developing that bond and promoting that retention. We've then developed education curricula for our patients as well, for a lot of different conditions, including heart failure. But as I mentioned, all of this about heart failure, we started working in this heart failure space in rural low-income countries because it's what we were seeing. As I mentioned, in Haiti, about 25% of the internal medicine ward are patients with heart failure. In Rwanda, it was about 15%. We're seeing very high burdens also in Liberia and Malawi. So they were the patients that we were seeing, and we were thinking that, oh, we need to give a way for them to get chronic care. But if you're a policymaker, one other challenge is that what the reality on the ground, particularly in rural low-income country settings, is actually very different from what the global discourse is on chronic diseases. This is from over 15 years ago from Nature, and this was saying, the grand challenge in chronic non-communicable diseases, research priorities for conditions, diabetes, stroke, and heart disease, where the face of non-communicable diseases for a long time has really been the lifestyle choices, smoking, obesity, unhealthy diet. And this really this has been embodied in a lot of the sustainable development goals, in global task forces, and a lot of working groups internationally. And so this is what the kind of the UN Sustainable Development Goals, which were goal to reduce, have a 25% reduction in CVD and other chronic disease mortality by 2025. Specifically for cardiovascular disease, they wanted to reduce CVD mortality by that same amount. But the targets to do that, the mechanism through which a lot of the global dialogue was to target things like alcohol consumption, physical inactivity, salt and sodium intake, tobacco use, treating elevated blood pressure, and avoiding increase in obesity and diabetes. These are very important, but if you look at these, like addressing many of these individual measures isn't going to move the needle in terms of heart failure management and heart failure burden in a low-income country setting. It's definitely going to have an impact in urban settings, places where there are a lot more stroke, urban settings where they're seeing more atherosclerotic heart disease or myocardial infarctions and heart attacks, but not if you're the rural poor living in a rural low-income country setting. And so our challenge then over the last decade or so was trying to figure out how do we impress upon policymakers that making some of these changes is really important. And so working together with a network that we've called the NCDI Poverty, or the Non-Communicable Diseases and Injuries of Poverty, which started as a Lancet Commission, has transformed into a movement that has a theory of change, where we start with phase one, which is a situation analysis and priority setting, where we prioritize conditions and interventions, particularly conditions that affect the poor, those that affect the young. Heart failure, rheumatic heart disease is one of those. Epilepsy is another one. Mental health, which didn't make it to the initial NCD targets, is also important. A lot of these chronic conditions share the same fact that they need chronic management, they need longitudinal management, so the same chronic care system can be delivered. We then work with sites to use integration science to figure out how do you integrate roles and tasks within individual teams of providers and teams of clinicians. Then we go on to a phase where we're doing initial implementation, and then finally scaling up and disseminating that. One of the major things that we've been promoting is an integration scheme that we've been calling PEN+. The WHO has a package of essential NCD care that is primarily for severe hypertension and type 2 diabetes that requires oral medications. But there are a lot of other patients that have more severe chronic conditions, things like heart failure, diabetes requiring insulin, more severe hypertension, that need care that's really just above what the WHO PEN program has. So we've developed what we're calling PEN+, and it really started from some of our early implementation at hospital levels. So this is working with teams that work at teams of clinicians working in clinical settings, in the outpatient settings, based at first level hospitals or district hospitals. Those teams can then develop extra skills in focused echocardiography, using glucose and hemoglobin A1C measurements, treating patients with DKA, understanding how to adjust medicines for heart failure, for diabetes, training them how to initiate and adjust insulin, recognizing diabetic ketoacidosis, for patients with sickle cell disease, initiating hydroxyurea. That team, that PEN+ team at the first level hospitals, can serve as trainers and mentors for those clinicians working at health centers, the WHO PEN model. and then also see patients in referral from health centers, and then give referrals up to the referral hospital as well. So we've been focusing a lot on training providers at first level hospitals, district hospitals, in how to integrate cardiac care into other severe NCD care, things like diabetes and diabetes and sickle cell disease. Our network has expanded over the last several years to involve providers at a lot of these hospitals, many of them in sub-Saharan Africa, also Haiti, also Southern South Asia as well. And a lot of this work we've been doing together and with a large team. But here I just want to summarize some of the challenges and the opportunities that I've spoken about today. We have a lot of rural patients with heart failure that cannot access cardiologists, so we've been targeting this with echo training for frontline clinicians. A lot of heterogeneous causes of heart failure, and we've simplified the diagnosis and the treatment categories. There's low uptake of evidence-based medications for heart failure, and we've simplified the management protocols. We haven't had enough experts for dissemination of our training. We've developed a master trainer model and incorporating other technologies. On the patient level, we have low linkage to care and low retention in care, and so we're piloting different patient engagement strategies. Understanding patients stop their medicines when they feel well, and we're targeting that with education. And on the policy level, the heart failure and other conditions that affect particularly the rural poor oftentimes are given low priority by international stakeholders, and we've kind of adjusted the priority setting within countries themselves and expanded our network. And avoiding having disease-specific vertical approaches, we've integrated heart failure care into other chronic disease care. So there's a large team that helps with this. A lot of what we're looking forward to is actually in the implementation science realm, because we have solutions for a lot of these things. We have medications that work, a way to diagnose these conditions of heart failure. But what we need to do is figure out how do we get these tools into the frontline conditions that can be at the right place at the right time, and how to do that as efficiently as possible. So thanks for inviting me. I know we have about 5 minutes left. I'm happy to take any further questions.
Thanks, Gene. We really appreciate having you. I know Lisa maybe has to jump off, so I can start with the Q&A. I'm Chad Achenbach. I'm the Associate Director of the Institute for Global Health. Again, thanks for coming, and what a great talk. One thing, I think you talked about a couple different approaches to decentralizing specialty care, cardiology specifically for you. But I guess, what do you think, going forward, what do you think the balance should be between kind of working with local rural primary care and teaching them specialty care, or how to do specialty diagnostics, versus training actual specialists in cardiology within country? I guess you talked kind of about both things, some countries that don't have cardiologists and you're trying to start programs, but then also how to decentralize that. I guess, where do you think you're going to have the biggest impact in the future?
Yeah, good question. They're not, as you mentioned, they're not mutually exclusive. Within our countries, we still need cardiologists to be able to do some of the more specialized evaluations. And then you also need cardiac surgery. I didn't even talk about that part, to help patients with valve disease that need surgery. That is very specialized, highly specialized care. But I think to have the most impact and the broadest impact, focusing on the first referral level hospitals and training those Penn Plus clinicians to be able to do heart failure care. Because once you have that team built up, they can then actually help the health center level, the level that's one level below, in addition to helping the patients that are coming with the heart failure. And you can get a long way regarding symptom relief and improvement in functional capacity and kind of ability to contribute to one's family just with medications, without the need of having specialists around. Even I, as a specialist, have to kind of acknowledge that you don't really need a lot of me's in local country settings.
Yeah, it makes sense. Okay, a couple great questions from the group here. One good one from Ariel Bell she's curious about the balance of breadth and depth in NCDI integrated care. So on a larger scale, or theoretically, how do we maintain depth of care while trying to develop integrated NCDI systems?
Yeah, so I think a lot of it really comes to careful selection of which conditions end up prioritized. Our goal is to have universal health coverage, but you have to start in a stepwise fashion. So for NCD care, starting with heart failure, starting with diabetes that requires insulin, sickle cell, treatment with hydroxyurea. Those were conditions that are affecting patients particularly severely, because when patients are affected with those conditions, they end up in the hospital a lot. When you're in the hospital, you're not contributing to your family and supporting your family. So starting with some of those conditions. Obviously, there's a lot of co-diagnosis with mental health and depression and anxiety with a lot of these. So those are some of the ways that we're going forward first. But then expanding next from there, thinking with local stakeholders about what their next priorities are, and trying to understand how do you integrate that into NCDI, and at what level of the system does that need to be?
Excellent. Another question is from the group here is, what do you think is the right amount of integration of cardiovascular disease screening and care into HIV clinics? And I guess we could take this to really any other chronic condition or disease. Just globally, there's been such a big rollout for treatment of HIV. It's an opportunity to work with potential populations. And I guess how do we integrate care for cardiovascular disease? We've done some integration with TB care and things like that, but we need to take it to another level. What do you think about cardiovascular disease screening and care?
Yeah, I really think about kind of integrating with HIV, and I like the term here was use clinics as opposed to HIV care. So there's integrating care for HIV patients with other conditions, right? Other comorbid conditions with HIV. And then there's using the HIV clinic as a platform for primary care, even for patients without HIV. I really think that's where we need to go. Over the last decades, we've had a lot of infrastructure developed to develop these very decentralized clinics, trying to figure out how to engage the most number of patients, even those without HIV, into those HIV clinics. The lowest hanging fruit, the highest prevalence of conditions are things like hypertension, where in sub-Saharan Africa, amongst adult populations, you have prevalences of 30 to 40%. That's so high that you're not going to be able to treat all of that within a district hospital-based clinic. There's just too many patients coming down into a hospital-based clinic. That has to be done at the most peripheral levels of the health center.
Yeah, that definitely makes sense. Okay, one final concluding question, which is a challenging one, but an important one. Do you have advice for recent college graduates who want to be involved in global health education? I guess maybe reflect on your own experience and how you've gotten involved in global health, and how do we get young people involved?
Yeah, I think part of it is, as getting exposed, coming to things like this, learning about it, and then getting some dirt between your toes. So going out into the field, really experiencing what global health is like, what are the challenges, what are the opportunities, figuring out what challenge really speaks to you. There are some challenges where there's a lot of momentum and a lot of movement. Decades ago it was HIV. Right now, if you're in the chronic disease space, it's hypertension. But there are other areas that really, think about what's really affecting the community and the patients there. And then that's what we've been doing with heart failure. It hasn't been an easy road. There hasn't been, dedicated funding. There's no heart failure global fund out there. It's really just going to fund heart failure care. But if it's important to the local populations and the local groups, then it's going to become something that's important to you as well. So experiencing what's out there, and actually just having a lot of grit and determination. There's going to be a lot of roadblocks. A lot of people are going to say no. There's going to be a lot of people that say that's too hard to do. But really just being persistent, if it's something you believe in, will help you move along the way. I've been told no lots of times. I've been told no. I've been told move to a different country or start working with a different group. I said no. These people need us, still able to help support them.
That's great advice, and you've done some amazing service. So thanks again for all the time and all your insights and experience. And thanks again to the audience for joining us and submitting your questions. We invite everyone to join us for our next installment of the Institute's seminar. That'll be on Friday, November 4th, featuring Dr. Hong Zhang from Harvard Medical School. again, thank you to everyone today. And if for anyone that's registered, a recording of the webinar will be available and shared via email. This concludes our webinar. Thanks, everyone. Thanks for coming. Any final things, Lisa? I see you're still on. Anything else to say?
No, just again, Jean, thanks so much for sharing. You didn't even go into some of the challenges about where some of the places that you're working and the real commitment to keeping the patient in the center of these of the work that you're doing, to making sure that people in need are getting the care based on what their need is, not where they are. So just want to thank you again for that, and thank everybody for their attention. And again, if you're interested in getting more engaged, please do join the Institute for Global Health. We have tremendous opportunities for people interested in expanding what they're doing and learning more. Thanks so much.
Thanks, everyone. Have a great weekend.
Thank you.